Is it here? What you want? What do you prefer?
Shall we start? Am I already? Okay. So good late afternoon, ladies and gentlemen, dear colleagues. Welcome to the second plenary of the European Public Health Conference. The creation of the European health data space holds the promise of great opportunities as one of the key components of strong European health union. The objective of the EHDS are to empower individuals through better digital health to their personal health data, support free movement by ensuring that data follow people, unleash the data economy by fostering a genuine single market for digital health service and products, and set up strict rules for the use of individuals' non-identifiable health data for research, innovation, policymaking and regulatory activities. This is especially relevant within the context of EUPHA's vision to enable everyone in Europe to achieve the highest possible level of health by providing independent and authoritative analysis of the evidence, combined with targeted advocacy to achieve coordinated action by all key stakeholders. The aim is to have the European health data space up and running in 2025, which seems quite ambitious. The EHDS is expected to bring great benefit, but also it brings challenges related to technology, governance, and privacy. The exchange of data at European level means that the health data from different sources need to be able to talk to each other, so interoperability is an issue here. What is needed is making the data fair, findable, accessible, interoperable, and reusable. This is a key to the success of the EHDS. While the diversity of Europe's health information system needs to be taken into account. Some countries are really ahead regarding their pace in digitalization. Some are lagging behind. Will EHDS really lead to equity, or lack of health digital literacy will exacerbate the health illiteracy? Finally, the EHDS will also have to be transparent to ensure privacy of personal information included in the EHDS. And is there enough trust among citizens, especially after the COVID-19 pandemic, where we experienced loss of trust in authorities? These challenges we will try to cover today with our wonderful panel. But before we start to giving a floor to our great panelists, to our great speakers, I would like to give now floor to my dear co-chair, Dr. Isabel de la Mata, Principal Advisor for Health and Crisis Management at DG SANTE at the European Commission.
Thank you very much, Iveta. Good afternoon to everybody. Yes, I'm Isabel de la Mata. We have EUPHA and the European Commission has been sharing a session for many, many years in the European Public Health Conference. So for this year, our topic is about the European Health Data Space. The European Health Data Space is something that we have been discussing in the European Commission, in the European Union for many years. Finally, we made a proposal. The Commission made a proposal in May, and currently we are discussing in the Council and in the Parliament. So, but don't think that this just affects the European Union. It's something we are presenting, and of course, will be a legislation, will be a regulation that is quite important for the European Union member states and for the territory, but the way that we are going to manage, that we are going to work, will affect also the rest of Europe. So what we intend in this session is that you understand, or that we will try to explain, is what we aim with this legislation, with this proposal, the main points of attention, how we are going to develop the challenges and how we intend to implement that. And then to see how this is affecting different stakeholders, so the patients, the member state, the scientists, so different entities, different part of the society. So for that, we will have first a presentation by Fulvia Raffaelli. Fulvia Raffaelli is our head of unit in charge of digital health in the European Commission, the General Directorate of Health and Food Safety. Fulvia joined very recently us, just 1 month and a half, and she has a very challenging task ahead of her. She came from DG Growth, but she has been working in the Commission since 2002. She is Italian, and she has a background in contemporary history, European political affairs, and political science. So, Fulvia, you have the floor.
Thank you very much, Isabel, and thank you very much for the invitation today. It's a great honor for me to be here to present, actually, the Commission proposal on the health data space to this very important audience, bringing actually together all the actors that would need to play a role in making the European data space a reality for our citizens. Every second, in fact, doctors, nurses, pharmacists, researchers, and health regulators all over the EU, but also farther than the EU, generate and use a large numbers of essential healthcare data. They are for their critical data which are critical to their life-saving work. Health data are the blood running through the veins of our healthcare systems. And the COVID pandemic has shown that up-to-date health data are key to take well-informed public health measures and to respond to crises. The pandemic has also triggered a huge acceleration in the uptake of digital tools. The challenge is now to keep the momentum and seize the opportunity to advance digital health for all member states and behind the European Union, and to make the healthcare system ready for the future and patient-centered even more than ever. Unfortunately, despite the major advancement in the digitalization of health data have been observed in the member states, but also in all member states, but also across the world, there are still complex obstacles that make it difficult to reach the full potential of digital health and health data. Let me mention 3 major issues. First, individuals' abilities to access health services is hampered by limitation in controlling their health data. People cannot always easily access their data electronically and often face issues in sharing the data with other health professionals. This is an issue especially cross-border, but also inside member states. Second, manufacturers of digital health services and products face barriers and additional costs as there is a variety of different standards and specification of various organizations. Third, is the limited secondary use of health data that puts limits on making more efficient and effective healthcare and public health policies. As we have seen during the COVID-19 pandemics, having access to accurate and timely information is crucial for effective health crisis management. Left click. the goal of the European Health Data Space is to overcome those obstacles. The European Health Data Space is a health-specific ecosystem comprised of rules, common standards and practices, infrastructure and governance frameworks that aims at, first of all, empowering individuals to increase digital access and control of their electronic personal health data and support their free movement. Second, fostering a genuine and transparent single market for electronic health record systems for relevant medical devices and for high-risk artificial intelligence systems. And third, providing a consistent, truthfully and efficient setup for the use of health data for research, innovation, policy making, and regulatory activities. The proposal has two main parts. First one on primary use, setting rules on how individuals can access, control, and share their data. And the second one is setting the conditions on how those data, after being anonymized, making completely anonymous, they can be reused for research, innovation, and policy making. The proposal is not, of course, isolated, and it is creating. It builds on existing legislative framework. It builds on the General Data Protection Regulation, the so-called GDPR, and on the proposed Data Governance Act, the Draft Data Act, and the EU Cybersecurity Framework. As horizontal frameworks, they provide rules, including security measures, that applies also to the health sector. However, the social sensitiveness of health data has been recognized and is today addressed by the current proposal. The security requirements set out in the European Health Data Space, notably as regards electronic health record systems, provide more specific requirements for health sector, such as access control. The European Data Space complements these initiatives and provides more tailored rules for the health sectors where needed. What are the expected benefits? The European Health Data Space will empower individuals across the EU to fully exercise their rights over their health data. People will be able to access their data immediately and free of charge and share this data while retaining greater control over them, fully in line with our overall EU approach to data protection. At the same time, the work of health professionals will be made easier and more effective. With improved interoperability, health professionals will be able to access a patient's medical history across borders, thus increasing the evidence base for decision and treatment and diagnosis, including when the patient data is in another EU country. Researchers will also benefit from a more direct way of obtaining access to data within a trusted and secure framework. Regulators and policymakers will also have easier access to health data for policy making and for better functioning of healthcare systems. This will lead to better access to healthcare, reduced costs, increased efficiency, more resilient health systems, new research and innovation, and enable more evidence-based policymaking. Last but not least, industry will also benefit from the EU-wide market for electronic health records systems, which is with the same standards and specifications. What are the benefits that we expect from the implementation of this regulation? Altogether, the Commission expects the primary use part to lead to better health outcomes for people as health professionals will have better evidence basis for treatment. It will also reduce the number of unnecessary tests and thus provide significant savings for patients and healthcare systems. We expect the financial benefits of primary use of health data to amount to 5.5 billion over 10 years. On secondary use, we expect a significant economic benefit of at least 5.4 billion over the next 10 years, coming mainly from 3 key areas: efficiency gain, data access, better information for policymakers and regulators, better value for patient healthcare providers and innovators, thanks to further use of health data. But who is going to pay for that? Yes, I will quickly go to the end. So both the Member States and European Commission will need to make available large amounts of funds, and a big breakthrough in terms of acceleration of digitalization in services will be required. We know this is a very ambitious objective, but we'll do, the Commission and the Member States together will make all efforts to make it a reality for the citizens. What I can say also at this stage is that, as said before, we are currently negotiating with the co-legislator. The entry into force, the adoption of the regulation is still expected within this Commission, so by mid-2024. 1 year of transition is foreseen for the entry into force of the bulk of the measures, and this will not come from nothing. We're building on a current experience. Many voluntary projects are already ongoing, and we are confident that with the support of the Member States, of different stakeholders and different actors involved into the chain, we will make of the European health data space a reality. Thank you.
Thank you very much, Fulvia. Thanks a lot for setting the scene. And now we are going to give space to our wonderful panelists, and we will start with Petronille Bogaert, she will reflect on how the EHDS aligns with the needs and level of maturity of national health information systems in Europe. Before I give you the floor, I would like to shortly introduce for you Petronille. Petronille is a project researcher and head of unit at the EU Health Information Systems and Sciensano, Belgium. Her work primarily focuses on European research projects in the area of population health information. She is coordinating the population health information research infrastructure for COVID-19, which aims to strengthen the exchange of COVID-19 health information with 41 partners from 30 countries. Other European projects she is involved in include the Joint Action Towards the European Health Data Space and the EHDS2 pilot. And last but not least, she is the president of the EUPHA section on public health monitoring and reporting. Petronille?
Thank you so much, Iveta. So indeed, is my microphone working? Yes, now you can hear me. Thank you so much, Iveta. So indeed, I've been working on different European projects in the past decade, I would say. And here it's important to see that what is difficult in countries is to be able to get access to data. So we have been assessing health information systems to really thoroughly understand what are these issues in countries. And what we've seen that is happening in the countries is that the data is fragmented. So often it's different organizations across countries who are hosting data. And that makes it difficult for a researcher or a policymaker that wants to get access to the data to know where the data is, but also it has consequences of linkage. So it's difficult to link databases that are in one organization compared to another. So what can we do to overcome this? One way to overcome this is to create metadata catalogs. Metadata catalogs describe what data is available where and how you can access it. And only few countries actually have national metadata catalogs. So usually you need to go to a certain organization and to ask them, do you have this indicator? Do you have this data? And there is not really a centrally organized place in countries where you can search what is available where. And therefore, the European health data space really needs to build up the capacity in the countries and the technical skills to build up these metadata catalogs. And in FIRI, we've already started doing that by building the European Health Information Portal. Now then, when you have been able to find where the data is, the biggest struggle is getting access to it. And I think many researchers here in the room have actually experienced that, you request the data, but the procedure is not very clear, it's complex, and it's taking a lot of time. A PhD takes 3 years, you need to have your results by the end, and sometimes it takes 3 years to actually get to data. So here, one of the things that we have seen and that we've been investigating in our different projects is working with federated data analysis. What that means is the data does not move outside of the organization where it is hosted, and it allows a secure processing environment for researchers to actually do the research on their data, and nothing exits the organization. And this is also an advantage because you can have a European question that is asked simultaneously at different locations, and this can be analyzed locally by the researchers to be able to provide a European answer to a question. So what is the difficulty there? Again, technical skills is really important, and we see that in other domains, this knowledge and the technical skills to build up these safe spaces or to be able to do federated data analysis is quite developed. But in our area of population health, there is really this lack of both having these ICT skills and this public health knowledge. So this is really something that we need to build up and to overcome the systematic lack of skills in countries. And the last element that I will bring up today is trust. I won't be talking about trust with citizens, although very important, but I will be talking about trust between organizations. So we've seen, for example, in the COVID-19 crisis, that organizations have been working closer together. And this allowed for data to be linked. And this allowed for actual sharing of data between organizations, which has been hugely important to be able to make thorough and evidence-informed policy decisions. So here in FIRI and TEDAS, we've seen that there is this general willingness to share data between organizations. But when we're setting this into practice, we actually see that with the implementation of the GDPR, there is a different interpretation, not only between countries, but actually also between organizations and within the countries. And this becomes quite complex, because one country will say, no, this you cannot access, and this other organization will say, yes, you can access. So the difficulty in the GDPR is really to be able to also to share the expertise and to share cases on how we've overcome some of the issues. And the GDPR has not been set up to limit the sharing of data, but actually to enhance it. And actually what we've seen, is that in countries sometimes the interpretation of the GDPR or national regulations have been set up that are much stricter than the GDPR itself. So how can we, besides setting up good legal frameworks and supporting each other on the exchange of how to interpret, what else can we do? Another thing which we found in our studies is that it's also important to set up the structural frameworks which allows these trust between organizations. So as I said before, by having these different organizations within the country, the data owners, the data handlers, potential or main data users come together in structured frameworks. This will really allow for people to know each other and also to have the structural and clear procedures on how to better exchange data. And it will be a real challenge after COVID-19, not only to maintain the exchange between the countries, but also to be able to continue that and to foster this trust that I think is so important. So in a nutshell, metadata catalogs, federated analysis, and trust. So let's build together on this with the EHDS. Thank you.
Thank you very much, Petronille. If you were wondering, that was a chronometer, because she asked me to do that at the beginning of the session, not that I wanted just to restrict her. We have different speakers, and we need to keep the time. At the end of the day, you are tired, everybody's tired, and then we will have the dinner that nobody would like to escape. So now we are presenting the different groups of people that will be affected by this regulation. So now we have Axelle Menu. She will reflect on what it means for a country, in this case is for France, to connect to the European health data space, and to what extent is the national health information system ready or not. and what will it take to connect? It's also true that there are countries that have been doing an effort before. There are countries that are more delayed, so that they haven't installed a system until now. So the ones that maybe it will be easier for the ones that have not done anything, because they could begin from scratch. The ones that have something will need maybe to adapt. So what is expected to bring for health policy research and policy making in France? So Axelle is a medical doctor and a specialist in medical informatics. She was working before in the APHP in Paris, and currently she's a medical expert in the Health Data Hub in France. So, Axelle.
Thank you, Isabel. First of all, on behalf of our directress, Stéphanie Combe, I would like to thank the organizer of the EPH conference for inviting the French Health Data Hub to contribute to this session. We are very honored in France and very enthusiastic to coordinate for the consortium that will lay the first bricks of the EHDS pilot for the secondary use of health data. To illustrate the perspective of our country, France, and to illustrate how we could, what we have done or what we are doing that may be useful or inspiring for the EHDS pilot. I will start with few examples, but I will also focus on some works of the EHDS pilot that will meet French needs. To set the scene, in France, it's almost very close to Belgium. When I listened to Petronille, I felt that we are close countries. Because to set the scene, in France, I point out like that in many European countries, France has an extremely rich heritage of health data. We have care reimbursement databases, registries, cohorts, hospital data warehouses, clinical trials data, and so on. But like many EU countries, we face difficulties to access those databases for research and innovation. These databases are managed by many institutions, public or private, with different governances, heterogeneous technical frameworks, or various procedures for sharing data. To facilitate and accelerate the reuse of health data for research and innovation in France in a harmonized, transparent, secure framework that respects the rights of individuals, the French state created 3 years ago the Health Data Hub. Thus, the Health Data Hub is the French health data access body for France. Among the actions and tools operational in France and certainly useful or inspiring for the EHDS pilot, I first mention the unique gateway for health data access. The unique gateway, it is a kind of one-stop shop. It's a team supporting research project leaders in terms of methodology, legal and technical aspects. It guarantees for France a unified and facilitated national procedure to obtain authorization to access data. Another inspiring example, maybe less mature than the example given by Petronille, is our metadata catalog. We are working on our metadata catalog. It's not achieved, but we are going to publish a first version in few weeks. And as Petronille explained it, a metadata catalog on a national level, it's a very useful and important tool to discover the databases, French databases. And in our metadata catalog, we will include a description of our national health insurance database. Finally, I will mention a work carried out by the Health Data Hub on health data interoperability. It's essential, Petronille described it also, and in France, we decided to use the HOMOP common data model, and we are working on mapping our French national claims database and transform it into the HOMOP common data model. And we are sure that this experience is going to be very useful for the EHDS pilot, because it's going to be a huge point on the European level to have interoperable databases. And our French experience with HOMOP will provide a wealth of information for the different use cases. To switch to the needs and expectations of French, I will only focus on one point. We have huge expectations on the necessary harmonization of regulatory frameworks related to health data transfers between EU member states. So to conclude, the EHDS pilot will produce many developments to which France is proud to contribute, but we are also confident that this project will meet needs that are currently not covered in France. Thank you very much.
Thank you very much, Axelle. Thanks a lot. Thanks for reflecting what EHDS means for one country, specifically for France. And we have already tackled a lot of promises, expectations, and challenges. And there is another big issue, the GDPR, the transparency, but at the same time, the privacy of the data, so the legal and law issues. And we have a great speaker for this topic, Irene Schlünder. She's a lawyer and expert in EU data protection law and database governance. She works for the Technology, Methods and Infrastructure for Networked Medical Research, a member-based German umbrella organization for academic biomedical research in Berlin. She is involved in various European health research projects, and as a member of the ELSI service research unit of the BBMRI ERIC. We have problems with abbreviations this evening, probably because of being a bit tired, where she works anyway on the initiative for a code of conduct for health research under the GDPR, and she will lead the legal work package of the EHDS2 pilot project, which has been already mentioned today. I met Irene for the first time in March in Edinburgh, and it's so nice to welcome you at the European Public Health Conference. Irene?
Thank you so much. Is it on? Yeah. Thank you so much, and I'm really happy, and thank you for the very kind invitation to speak here. Yeah, I'm representing more or less the biomedical research community, and we had the discussion that there might be a little bit of distinction between the communities of public health on the one side and biomedical research on the other side. Let me start with our research community has been complaining about GDPR since it is in place, about fragmentation, about bureaucratic burden. So most of our members are really happy about that initiative of the EHDS, that there's a move towards data sharing, and there are big expectations and hopes that it will be easier, that EHDS will facilitate access for researchers to data and data sharing. So the EHDS initiative is highly welcome, but I'm the lawyer and I'm the GDPR expert, so I'm not here to only praise the proposal, but I'm here to raise some concerns because it's still in discussion and I think there can be improvements. First, I think the scope of the EHDS draft proposal, so we have a regulation proposal already, is a little bit too broad for a lawyer's taste. We have a very loose and vague definition of health data, so it in the end includes even, let's say, administrative health data. So in the end, my phone number I give to my general practitioner. I know that this is not the intention, but by the wording, it's now as it is. It includes even a wellness app data, yeah, it's quite, it includes almost everything from a perspective of a citizen. And then every natural person and every entity who has somehow, yeah, access or holds data, whatever that means, has the obligation to make those data available. So this is really, let's say, not very precise. So citizens will have some difficulties to understand what they have to expect from the EHDS. And from a yeah, legal perspective, that's a little bit of a problem. Second point is that when I talk to the research community, they are not fully aware what it means for the researchers. We have here a landscape that has spent huge effort and money on building excellent databases for research data. Yeah, researchers will not only be in a position to get better access to data, they will also be in a position to deliver data. So I have my doubts that everybody has understood this, to be honest. And on the other hand, the access to data is quite streamlined, so it might be less than they have now in a certain way. So the access is limited to anonymized data sets, to on-site research, to yeah, in a secure processing environment. But normally the research community is more used to just exchange data. So they are pseudonymized, there is a data protection framework around, but it's in that respect much easier to get access to data under some circumstances in collaborative projects and so on. So I'm not so sure that, that the EHDS proposal seems to be even a little bit limiting the data sharing and use there. I read it as such, so we can discuss, but I think we should not really exclude yeah, we have to discuss about how to connect to the very lively research community and the databases that are out there. My last point, but that is more Kaisa who will expand on it, is everybody's talking about patient and citizen empowerment. What I now see in the EHDS proposal is more a limitation of the rights of citizens and patients with regard to the rights provided by GDPR, especially Article 14 as GDPR is mentioned, that is derogated completely. And I do not see concrete rights for citizens and patients to go to a supervisory authority, to maybe even get damage compensation or something. And I even would propose to learn something from consumer law. Maybe patient organizations should even have the right to represent groups of citizens and patients. I don't know, it's just, I'm thinking aloud here. Yeah, I think my time is over. So thank you very much.
Thank you very much, Axelle. Irene, sorry. And finally, the patients. So at the end, everything, this regulation, the discussion about the health data is about the patient, or the citizens in general, because we will have data not only on patients, but on population in general. So what do you expect, what benefits you think, or what challenges, risks even, that will bring? For that, we have Kaisa Immonen. You have already heard her in the first plenary today. But just to say that Kaisa is the director of policy at the European Patients Forum, and that she has a master's degree in health policy and international relations, and that she has been working in the EPF for a time, and now And she has been also the co-chair of the European Medicines Agency's Patients and Consumer Working Party for the last 6 years. So we could say more things about her, but I think that you have here this morning, and in any case, we already know who Kaisa is, so 5 minutes.
Thanks very much for the invitation. Yes, I'm here to represent a patient organization, of course, but I'm going to speak about patients and citizens because the European Health Data Space involves everybody. And I should also say that, I will come to that, not all groups of patients, even if I talk only about patients, would be impacted in the same way by the provisions of the European Health Data Space. So we have, obviously we're engaging in this legislation as a European patient organization very heavily, and we have made proposals for amendments. I'm just going to focus on a couple of points to be concise. From our perspective, the potential for patients to have control of their health data is so important. This is one of the cornerstones of empowerment, to have access to your own health information. Right now, even patients' access to their own health data is not a given everywhere, and we are in 2022. So we look forward to that, and that will require a common format in which patients will receive their data for everybody to have it in an equal way, to be tailored according to disease areas. There should be some flexibility there, and it should be presented in a format that people can understand. No one should need a dictionary or a glossary to understand their health data. I should say that the patient community, on average, are more willing to share their data than the general population. There are two main benefits that our community sees for secondary use. One is obviously research into new and better treatments. The other is information to guide health systems decision-making, policy-making for better quality, more joined up and integrated care, so to improve quality and patient-centeredness of care. We asked our members in 2020 about electronic health records, and one part of the survey was about willingness to share their data. And more than 50% of the people who responded were happy for their data to be shared for research and public health purposes, even without consent or with very broad consent. Around 35% wanted more strict consent provisions. There are some challenges from the patient perspective. As I said, different groups would be impacted in different ways, and without trust, it won't work. One of the main concerns that we see is that data might get into the wrong hands. So it could be insurance providers, employers, or non-medical companies. Given that privacy is not a given in a world with big data and multiple data sets, even de-identified information could become identifiable through triangulation. Some people do worry about that. Some patient groups, maybe those who face discrimination, some people who may be marginalized in society or could be less willing to share their data, and I think their legitimate concerns will need to be addressed, and the safeguards need to be there. Others want to share as much as possible. We see that particularly in the rare disease field, where people just take the data and give us the treatment. The willingness to share data is affected by several things, including what we found in our survey, the safeguards about privacy and anonymity, the reassurance of effective ethical oversight of the system, and knowing who's doing the research and for what purposes. Now, some respondents make a difference between commercial and non-commercial actors, but not everybody. But the point is, people want to know who's using the data. And I think here the proposals could also be more robust in terms of, I'm sure there are systems to inform people to the extent that they want to know. And I think trust also needs to be built in through transparency. A fit-for-purpose system for consent that will enable data sharing whilst respecting fundamental rights, and assurances that the data will be used in the right ways for the right purposes. We don't want data sets, and I think you come here to the FAIR principles that Fulvia also mentioned. We don't want data sets being kept by commercial companies so they cannot be accessed by other researchers. We think the data should be used for purposes that bring benefit to patients, to society, and the end products being developed with this very wide sharing of citizens' data need to be accessible and affordable to the people and to the health systems that will have to provide them. And we also want appropriate sanctions for misuse of data. That currently, I think it could be strengthened in the proposal. But it's a work in progress, and our community is very, very, very actively involved in the discussions at the moment going on. Thank you.
Thank you very much. Kaisa, thank you very much. We are very often forgetting the patients, and therefore I'm glad that you brought this perspective and you informed us that how the patient feel about EHDS and what are the challenges. And I think we heard a lot of questions and a lot of answers we had, but I like to be provocative, to be honest, and I would like to give you a little bit of tricky question. So my question is, how the member states responded to the plans so far? Is there enthusiasm, or are they more reserved? We heard Irene has some concerns, but what about member states in general? What is your observation? What is your experience? Yeah.
Member states, actually, the first reaction from member states are very supportive of the overall project. This was already in the first Council declaration after the adoption of the proposal. They are supportive of the overall objectives of the regulation. They also very much aware of the fact that this is very ambitious. So they, of course, measures, let's say, their support to the proposal with their starting point, where they are. We know that today the situation across member states is very different. Some are very well advanced. Some have experience in primary and in secondary use of data. Some are starting almost from scratch. This is why it's so important, actually, the voluntary work that we're doing already with the member states. First of all, the My Health at EU project, which is already a reality, connecting 11 member states and exchanging already in real life e-prescriptions and patient summaries. Will be joined by the other member states and with also some EFTA country by 2025. So we are really working with the member states, and they are part of this game. They are very participative of all different projects we've been running. We heard also from the French experiences, from the Belgian one, and we also, they have doubts, of course, they have questions, we go into it, but all in all, they are very supportive of the overall objectives of the setting up the EHDS.
Thanks a lot. And what about health literacy? Is insufficient health literacy or digital skills make differences between the countries, or does it lead to more equity, or is it exacerbates the inequity?
Well, unfortunately, digital literacy is a reality. It is not only affecting health data. It is indeed very horizontal problems that cut across in many different areas. The Commission is working with the member states to set up specific projects to actually enhance the situation there. But please also do notice that the access to data will remain also in the future regulated at the national level. So actually the GDPR will continue to apply in parallel to the EHDS. So the access to data would not only be limited to digital data. Data could also be obtained under different formats. So this is of course a long-term travel trip, the one that we will do together also with other different sectors working on improving actually the reality and the education, digital literacy all across member states.
Yeah, thank you. I know that Petronille wanted to have a quick comment on that. Is it still?
Yeah, I just wanted to say that we went into 11 countries specifically asking about the EHDS, and in general, indeed, there was a willingness to share data.
But I think at the same time, the concept of the EHDS is sometimes a bit misunderstood. So people think we want to create a huge database, and that's really not the idea about the EHDS. The idea about the EHDS is to create the pipelines to be able to connect the data between the different countries. And that's, I think, an important comment to add. Thank you.
If there is anyone in the public that has a question, there is a micro just there. You can go and make the question. You have a question? Okay.
Very good.
No?
No, no.
Yeah. Okay.
Yes, we have a question from the audience.
I'm very
Great.
interested.
Can we turn the microphone on?
1, 2, 3. I wonder how this federated translates to linkage. So you're saying both, but obviously these two exclude each other.
So your question is how federated analysis overcomes the linkage issue? Is that
No,
correct?
it can't. It must be the other way around. So linkage needs to overcome the federated idea. So the data need to be transported in order to be linked, as far as I understand. So we need to be honest. This is more than you said.
Yeah.
If you want to make data accessible, that means they need to be transported, they need to be linked, they need to be transported to other places in order to be analyzable.
Yes, of course. The setting I was talking about is if you have a research question that you want to be analyzed in different countries. So there, of course, to be able to respond to a certain research question, the data still needs to be linked within the country. But you could, through federated analysis, be able to run analyses that are common between different countries. So, of course, you need an element of linkage, which is essential. That's why the countries where data is hosted in the same organization, they have really a wealth and an additional element to be able to do research, because you have all these different types of data sets that you could link. But unfortunately, the reality is that in many countries, the data is hosted in different organizations. So federated analysis can help with that, to be able to address European questions. But of course, if that question requires for different data sets to be combined, they still need to be combined locally. Yes, good point.
Thank you. I have a question probably for Irene, but also maybe for Kaisa and Axelle. One of the keys for the success of this regulation is that the people trust the citizens, but also the health professionals. So how we are going to convince, how we are going to achieve this trust for that people think, that they feel that the data are safe, and that they can be used for the right purposes, and that they are not going to be sold or to be leaked or something similar. Irene? Yeah.
Maybe both. You could
Yeah. And even Axelle, because she is the health professional, so not only the citizens, the health professionals also need to be convinced that whatever they are collecting is going to be safe. So maybe the three of you, short.
Yeah, in my view, transparency is key. So as Kaisa has already pointed out, there must be means to inform people what is done with their data. So I'm a little bit reluctant to accept that the information rights of patients are just derogated. We need to discuss how transparency then is achieved. Then there's a huge discussion going on since ages now about consent, opt-in, opt-out. I think the discussion is not yet totally has come to an end and result. If we go for consent, or if we go maybe in some countries for consent and in others not, we urgently need a better standardized consent form and procedure. And this is again for the benefit of patients. If you have to go through different consent forms and read it again and understand it again, that's a huge issue. It's not only a bureaucratic burden for researchers or whoever collects consent, it's also a burden for patients. We need standards also not only for interoperability of data, that's another issue, but we need a standard how to inform patients, how to get they're opt-in, opt-out, whatever. I do not see a huge difference between opt-in and opt-out, because an honest opt-out would mean that you anyway inform patients. So the procedure is not so different in the end, but we need better streamlined procedures on that and standards.
Yeah, thank you. No, I subscribe to that, and we're also discussing the consent issue still in our community. I don't think we are at the conclusion yet of the discussions, and it's not going to be very simple. But I would also add here the element of governance, because we believe that one of the success factors of the European Health Data Space will lie in its ability to reach out to patients and citizens, but also to be shaped with them. And inclusive governance is one of the things we'd like to see. So patients and other civil society should have a place in the governance structures. There is the European Health Data Space Board at European level, and in member states there are varying arrangements. I believe in France there is a patient representative and the national body, so it's certainly possible. This is good for transparency, for legitimacy, for accountability, but also bring the expertise from the community to ensure that questions can be addressed and patients' need can be taken into consideration, for example, when discussing ethics or safety, such issues.
Very good. Now, we will stop here for time being, okay? We have 2 more questions from the audience, and I would like to give a space to our audience. So I suggest that you both of you ask the question, and then we give the panel for the final thoughts and for the final reflections. Is that okay? I hope we can stretch a little bit the plenary by 5 minutes. So please, the gentleman on my right-hand side.
Yes, Herman van Ooyen from Belgium. It's not more a question, it's also...
Closer to the mic, we don't hear you. Closer to the mic.
Yeah. Herman van Ooyen from Belgium. It's not as much as a question, but it's also more a comment. I think the positive thing is that we are currently discussing this. Okay? And the issues are very complex because it's not about patients only, it's about total population. If we know that, in fact, the health of population, healthcare is only a very small fraction. It's determined by choices people make, but also things that happen in their environment, their physical environment and the social environment. So if we want to understand that, we really have to go beyond, in fact, just healthcare. But of course, healthcare may be the most concrete one. Yeah. And in that, we have also different elements. We have data that are collected by biomedical research. We have data that are collected within the healthcare system. And we have data that are collected, in fact, outside the healthcare system, but also at population level. And there we have also, and so a lot of elements that are also mentioned by, I think, the lawyer are very, very useful and very thoughtful that we have to think about. How can we, in fact, combine those elements really so that, in fact, at the one side, we have the individual right that ensure that whatever data there exists from him, and that can be health and non-health data that influence health, okay, are used in the right way and how to do that. But on the other hand, how can, in fact, research community engage and that they also can reuse the existing data that are really there. Yeah. And I think the example that was given by France by having, in fact, a standardization approach, we need that at the European Commission, because the most of the frustrating element that people currently have is that it is different everywhere. And so you have no assurance that whatever you want to achieve, that it will be feasible, because you will always have different approaches. And therefore, I think also what the mentioning of I will just say the lawyer, and maybe not very polite to say it in this way, is in fact that we really need a standardization on that, so that people can really find out how to do it, what to do it, and for the different perspective as such. Thank you.
Thank you very much for this excellent comment, and you had an applaud from the audience. I think a little bit Kaisa touched upon it when she was mentioning the integrated care, and we know that within the context of overburdened and overstretched healthcare systems, we definitely need to take into account also the social care. We first will give space to the gentleman on the left-hand side, so please, the question.
Timo Clemens, Maastricht University. Maastricht is based in the Eurasian Maas Rhine, which has a long tradition of cross-border projects in terms of healthcare, and definitely involving flow of data, particularly for primary purposes, according to the European Health Data Space. We just finalized an ex-ante impact assessment on the proposal for the EU-Regio, and practitioners from the field generally appreciate the proposal, particularly for the secondary purposes, but they share the concerns of Irene as well on how far can our existing data flow processes that partly are based on European regulation but are partly tailor-made continue to exist with the European health data space, because they are building on trust and tailor-made solutions.
So now,
Quick answer.
yeah, quick answer will be the final round. So each of you, if you want to say something to respond to previous questions, these questions, so opportunity.
Yes, very briefly, I would like to confirm and actually that the trust is the key words for the functioning and for the EHDS to become a reality, let's say. I think that there are two different ways of looking at the right of the patient. The first one is looking at the right of actually not only the patient, but of the citizens, individuals, from the primary use. And the EHDS will give complete control of the health data to each one of the individuals, because it will be able to decide to whom to transfer the data, also to delete or to obscure some of the data that is not feeling comfortable with, and of course to access his data immediately and free of charge. So these are the EHDS is giving control at the moment that not always the patient has today. Different is the situation for the secondary use. This is giving access to only anonymized data. In this case, it's true, we do not foresee a specific consent, but we do foresee actually that all the requests introduced by the data users will be published together with the results of the research. So the collective, the cumulative results of the use will be published, and also only in very specific cases where the data needs to, where the data users need to have access to pseudonymized data, then this will only happen in very secure environment. So the idea is that really to prevent any possibility to re-identify back the individual that comes at the beginning of the data, or the data processing. These are the two, let's say, conditions that shouldn't actually create a very trustful environment for the individuals we are. He has the control at the beginning as far as the private use of data is concerned, and he has strong conditions for the access to this data afterwards they are anonymized or pseudonymized.
Okay, Axelle?
Yes, I'm going to give some words about enthusiasm to answer to the first question of Iveta. I will give the testimony about the enthusiasm of the countries who are contributing with France to the EHDS. It's difficult for me to say all those concepts. EHDS pilot. France decided to respond to a call for tenders of the European community, and it has been very easy for us to find colleagues as enthusiastic as us. So it is France, Belgium, Germany, Finland, Norway, Hungary, Croatia, and I hope I'm not forgetting someone. So the call for tenders was very important, because to build a proposal for an EHDS pilot for secondary use of data, it's a quite an important job, and it has been very easy to find volunteers countries. And in few months, we have been able, with the 8 countries, with research infrastructure, international, and with a European agency, EMA and ECDC, we have been able in few months to build an interesting proposal. It has been selected by the European community, and I really want to focus on that because we are animated by that, and the delay is short. We have 2 years to try, to test, and to build some bricks, but the enthusiasm is there, and I would like to say it, to finish.
Kaisa, 2 minutes maximum.
Okay,
Or one.
I'm not going to say much because I think I've said everything. But I would just, from our community's point of view, we want to avoid a situation where, let's say, there's patients in different European member states will end up in different positions with regards to being able to exercise their rights. This proposal treads a delicate balance between European and national, I mean the need to harmonize and yet the need to respect national competencies. So I hope that in the coming discussions, the policymakers, also national ones, will respect the patient perspective and take our concerns into account. And I think the trust element will come through concrete actions and concrete provisions that will enable the trust. And I think we still have a lot of communication to do as well towards our communities, and to create that understanding of what the EHDS is and what it isn't, what it will do and what it won't do. Yeah. So I think the journey in that case is only just beginning.
Okay. Irene?
Thank you. It's working? Yeah. Yeah, as I've stated already, my main concern is that due to the broad and even a little bit loose scope, that the whole thing will not really be implementable. And this is, something that I would really regret. I think we have the responsibility. There are high expectations, there's a high potential in it, in the idea, in the vision, and we have somehow a responsibility to make that fly.
Absolutely, thank you.
And so I think that due to this, I would love to see a little bit more focus. So legally speaking, a better definition of the data holders, who really is obliged to deliver data, what data. So cannot be any natural person who is just able to deliver. So that's not a definition I could work with. And citizens have to be in a position to really understand what is at stake. And the same is true for our research community, because they are still struggling to find out what is here on the horizon.
Petronille?
So I think we have a wealth of data across Europe, and I think it's really important for us to make use of that, especially the secondary use. There is so much data out there that is just standing in a server somewhere that is not being used. We put a lot of energy, a lot of effort to collecting all this data, so I think it's a pity if we don't make the fullest use of that data that is available. And so I think the vision of this EHDS is really making sure that we improve the population's health, we make the evidence available so that policymakers can make good decisions. And I think the EHDS has a huge ambition, and it's really our common also responsibility to, in short steps, really also make it feasible. So we're really gonna have to break it down, have some feasible results that we can showcase, and we are trying to do that through the EHDS2 pilot, but also it will require, I think, all of our common support as well across countries to make this vision reality.
So thank you very much to all the speakers, the 5 of you, different visions for the same proposal, or not different visions, but how affect to different groups of the population. Just for everybody, remember, this is a proposal for a regulation. Regulation means that one that is approved is nothing to be discussed. It's not a directive that has to be transposed in national law. That is set once that the day that has been approved. So now there is the time in the Parliament, in the Council. If you have something to say, you have your representatives in the Parliament, in the European Parliament, national parliaments, the representatives of the Ministries of Health that are discussing that with Fulvia. And so you have the opportunity. Still, the aim of the Commission is to have this approved during this mandate. This mandate is going to finish in 2024, so we have 2 years. We will prefer that we don't need to exhaust the 2 years, but that will be possible to approve in 1 year. But we are aware of how things work and the difficulties, and it's a really difficult piece of legislation that, and once that will be approved, we are not going to modify in 2 years. It will be for a long time. So it's better that we think about all the potential implications and that we approve something that we all are really convinced of. And that we take the steps that have already been presented, the financial, the timing, derogations, step by step, and etc. So thank you very much for being here today and for presenting this and to give some hints on potential challenges. And
thank you very much, Isabel. Also, on behalf of EUPHA, I would like to thank you all also for coming here and contributing to the discussions. Obviously, this is a very complex agenda, and I'm not sure whether we answered the questions or whether we raised more questions. But what I really appreciate that the Isabel's call for action. So now really is the time to do something about it and to use the opportunity to comment. And without further ado, I would like to really close this session, this plenary. Thanks a lot once again for excellent panelists and the speaker. And now I would like to invite you on behalf of the European Public Health Association and our partners to a welcome reception, which is in the conference hall. So we have a small break, 5 minutes approximately. Formally, we should start at 7 o'clock, the reception. Yes, thank you very much once again.
Thank you. Thank you, Iveta. Thank you, Isabel.
Done.